The next speaker, Dr. Monalisa, she's gonna speak on Azetreonam and Avibactam as an empirical choice in nosocomial ICU.
Good evening, all. I thank the Critic 2024 Society for giving me an opportunity. My previous speaker has spoken about the age-old drug, the polymyxin, its advantages, and choosing it as an empirical therapy. But I shall be delving upon the empiric choice of Avibactam Azetreonam in these days. Uh, as we know, like there has been a increasing impact of the MDR bugs, and they've got a severe impact, like increasing the mortality rates, decreasing the treatment effectiveness, prolonging the illness, incurring a high cost burden. And similarly, so these problems are very important, and we should be choosing the empirical choice very wisely. So the empiric regimen is to be based upon what organism we isolate in our ICUs, what is the organism isolated and its antimicrobial susceptibility patterns, the previous antimicrobial exposure of the patient in the previous 30 days, and the local antibiogram. So these three factors need to be kept in mind prior to choosing the empirical therapy. For this, we should be knowing what is the organism. So coming to the ICMR data, the annual report which was published in 2023, which shows what are the organisms that are prevalent in our settings. So the most common organisms that we come across are the Klebsiella and the E. coli being the two most common ones. And this pattern has been there since the 2017. And the Acinetobacter is only the third organism, or at least maybe equivalent to the Pseudomonas, the third or the fourth organism. So in our setting, it is not the Acinetobacter that we're mostly concerned with. It is the Klebsiella and the E. coli which are more concerning. And as you can see, this is the data of which are the more common organisms. In all of these, the E. coli and the Klebsiella are the predominant ones, contributing to about 30 and 28% of the cases. And the Acinetobacter only comes in the third or the fourth position, and the Staph aureus being the fifth one. So keeping in mind the organisms that we isolate in our ICUs and the wards, the empiric choice should be similar. And these are the resistance genes that we isolate. The OXA48 and the NDM and the WIM are the most common ones. And the SHV is also seen in quite a number of cases of the Klebsiella and the E. coli. So what is the rationale of the combination of the ceftazidime avibactam with Azetreonam? As we know, the ceftazidime is the third generation cephalosporin which binds to the PBPs and inhibits the peptidoglycan cross-linking, thus preventing the cell wall synthesis and causing the cell lysis. Avibactam is the beta-lactamase inhibitor without any intrinsic antimicrobial activity, but protects the ceftazidime from degradation from the various serine lactamases, and thus it is also a reversible action, but it is active only against the OXA48 KPC and the AMC beta lactamases, and the MBLs are not prevented by it. Coming to the Azetreonam, it is a monobactam. It is stable to the hydrolysis by the MBLs. Thus, the combination of these restores the ability of the enterobacteriaceae against these carbapenemase producing enzymes. This is the pictorial representation. As you can see, the MBLs destroy most of the beta-lactam BLI combinations and even the carbapenems, but the Azetreonam is stable against the hydrolysis. So when there is a combination of the Azetreonam and Avibactam, it stands as a shield against these MBL and OXA48 producing organisms, thus giving us a better outcome. There have been several trials which have proven the efficacy of the ceftazidime avibactam combination and also the Azetreonam combination. My previous speaker spoke more about the theory pattern, and there were like very less lacking of the real world studies which show the effectiveness of this. But I shall be going with a large number of studies which prove the fact. As you can see, there have been several trials like the Reclaim trial, the Recapture, Reprove, and the Reprise trials, which included the intra-abdominal infections, the complicated urinary tract infections, the HAP and the VAP cases. So all of these have proven that the key findings showed that the ceftazidime avibactam combination fared very well as to the comparator drugs, which included the carbapenems as well as the polymyxin groups. Coming to the study which compared the colistin with the ceftazidime avibactam, it was published way back in 2020, and then it included it is a multi-center trial which included the patients, 137 patients, of whom 98 were given the colistin and about 38 of them were given the ceftazidime avibactam, and it was shown that the outcomes wherein more the adjusted all-cause mortality at the 30 days was 9% in the case of ceftazidime avibactam group as compared to the 32% in the colistin group. The difference was 23%, which is very significant. Coming to the studies from India, this is the study which was published by Dr. Vasant Nagvekar from Mumbai. We showed that the clinical outcome in the patients on ceftazidime avibactam CRE, they included about 119 patients, of which 45 of them were given the ceftazidime avibactam, and the outcome was better. The overall mortality was lower in the group which was given the ceftazidime avibactam. Another real world study from India, a few of them authors are also there in the hall. The ceftazidime avibactam alone or in combination with Azetreonam versus the polymyxins, the Capri study, which showed that which it included about the isolates from Jan 2020 to September 2022, and included about 106 patients, of which 65 received polymyxin and 41 received ceftazidime avibactam with or without Azetreonam. And the conclusion was that there was a better clinical outcome in the patients who received the ceftazidime avibactam, as the mortality was lower in the group of the ceftazidime avibactam group. Another cohort study from India which showed the similar outcomes, the comparative efficacy of ceftazidime avibactam versus polymyxins. The treatment with ceftazidime avibactam had a better clinical response as compared to the polymyxin monotherapy, although there was no significant difference in the microbiological outcome. Another study which was published from Kochi, the clinical outcomes in the patients with carbapenem resistant Enterobacteriaceae. It also showed that the outcome was better in the group who were given the ceftazidime avibactam empirically as compared to the polymyxin group. It included 103 patients. And another Indian study, like there are a lot of Indian studies, these are the Indian data, which shows that in our setup, the ceftazidime avibactam and Azetreonam combination fares well. This was the study by Dr. Subramaniam Swaminathan, who showed that early initiation of ceftazidime avibactam was associated with a lower clinical failure. As you can see, if it is initiated within the initial 48 hours, the outcome is very good, like the clinical failure rates are 18%. And if it is delayed, the initiation is delayed, it can be as high as 69%. We have also done a meta-analysis of the usage of ceftazidime avibactam in the patients who have isolated Pseudomonas aeruginosa, and the outcomes, the conclusions were that the ceftazidime avibactam treatment was associated with a lower in-hospital mortality in the patient group with the MDR Pseudomonas infections as well. This is another systematic analysis comparing Cas-Avi with the comparator groups with a similar outcome. There are several studies to substantiate our data, and this study also shows that the data is more robust in cases of polymyxin B as a comparator. So the outcomes, as you can see, the polymyxin group has a poorer clinical outcome as compared to the ceftazidime avibactam group. Coming to the ceftazidime avibactam with Azetreonam combination, there has been a trial in the Latin America, Europe, and Asia, including 20 countries, and they have shown that they have taken the isolates from 2019 to 2021, and the in vitro studies have shown that the Azetreonam avibactam combination inhibits about 99.6% of the isolates of the carbapenem resistance enterobacterials, and even the isolates which are resistant to ceftazidime avibactam alone were sensitive to the ceftazidime avibactam Azetreonam combinations. There is another trial, the combined trial, which shows the efficacy. Coming to the another trial which has been in the phase 3, which is published in the Lancet, published last month, the Azetreonam avibactam combination versus the meropenem, the revisit trial. So the study design includes 20 countries across the various continents, and it is a phase 3 trial. The patients were mostly the complicated intra-abdominal infection patients and the HAP and VAP patients, and the groups were very well comparable. And there were 462 patients with about 281 being given the ceftazidime avibactam. And the outcome data showed that the Azetreonam avibactam combination had a better outcome as compared to the comparator polymyxin B. Coming to the guidelines that have been given by the ICMR, states that for the NDM isolates, it is the first drug of choice is the ceftazidime avibactam with Azetreonam. For the NDMs with OXA48, it is again the ceftazidime avibactam with Azetreonam. OXA48 like it is the ceftazidime avibactam. And even for the Pseudomonas, it is or the Acinetobacter, it is not the polymyxin B which is suggested the first choice. but it is the sulbactam based combination which is the first drug of choice in this case of the Acinetobacter or the Pseudomonas. So as my previous speaker said, even for the Acinetobacter, the polymyxin B is not as the first choice. It is the high dose sulbactam based therapy which has been suggested. Coming to the IDSA guidelines which have been published last month, this also states that for the patients who are having a CRE with MBL, the ceftazidime avibactam combination is the first drug of choice. And coming to the role of polymyxins, polymyxin or colistin B are not suggested for the treatment. It is stated in the guidelines. And coming for the approach of the CRAB patients with the carbapenem resistant Acinetobacter, it is the sulbactam based therapy which is the first drug of choice, and the alternative agent is the polymyxin based therapy. So all these studies and even the guidelines have suggested that polymyxin B therapy is not the drug of choice to be started with, and it is definitely the ceftazidime avibactam combination for the Klebsiella and the our E. coli, and for the Acinetobacter it is the high dose sulbactam based therapy, not the polymyxin based therapy. Thank you.